I'm going to talk this morning about interpreting viral suppression data. And the advent of virus load monitoring really revolutionized our approach to HIV care. And you would think that this is a fairly simple concept. Either people have detectable viremia or they're undetectable, and the goal of treatment, of course, is to make people undetectable. But because the assays for measuring virus load have changed over the years, and our definition of undetectable has changed over the years, as these assays have become more precise, the issue has actually become a little bit more complicated. And I'll try to walk you through some of those complexities, and I'll present several studies that we've published over the years. I'll probably skip over the methods and the details, but I'm happy to share my slides because all the work that I'll be talking about has been published. So first, these are my disclosures. So why do we worry so much about viral suppression when we talk about antiretroviral therapy? Well, as you know, RNA viruses, and HIV in particular, is really, as a population, comprises a quasi-species. That is, in any infected person, there are thousands and thousands of unique sequences, each of which are closely related, but distinguishable from one another by doing sequence analysis. And these genetically distinct variants evolve from an initial oligoclonal inoculum. A single virus or one or two viruses succeed in establishing infection and then diversify because of the error-prone RNA-dependent polymerase. In the case of HIV, this is the reverse transcriptase. If we were talking about influenza or dengue virus, it would be an RNA-dependent RNA polymerase. Now, the viral genome is about 10,000 nucleotides long, and there's a mistake made at least once per genome in every replication cycle, given the error rate of reverse transcriptase. And based on what we know about the number of rounds of replication every day in an untreated person, which are somewhere between 10 and 100 million rounds of replication per day, you can see that every single possible error can be made many times over across these 10,000 bases if the patient is not on suppressive antiretroviral therapy. So that means inadequate suppression will select rapidly for drug resistance mutations, and the accumulation of these mutations leads to broader and broader cross-resistance within a class. And we learned this the hard way in the early era of nucleoside analog RT inhibitors with AZT and didanosine and D4T, where the long-term use of failing therapies just allowed more and more mutations to accumulate until none of the drugs in the class were of any use, and we went through the same experience with the early protease inhibitor era. So for that reason, complete suppression of viral replication is really essential in order to be able to have a durable benefit from treatment. So the key treatment goals, as listed by the DHHS Antiretroviral Treatment Guidelines panel in their most recent update that's now about a year old, and the next update is expected sometime this summer. But these are goals shared by guidelines from around the world, and that is treatment should maximally and durably suppress plasma viremia. The goal is to restore and preserve immunologic function, to reduce HIV-associated morbidity and prolong the duration and quality of survival, and of course, to prevent HIV transmission. Now, although understanding suppression is easy, there's no virus, there are many different ways of describing viral failure. So you can have overt virologic failure. So you simply cannot suppress plasma viremia. You can't get to less than 200 copies. Or you might have an incomplete response. You which means that after 6 months of treatment, 24 weeks, you still have detectable viremia above 200 copies in someone who's never gotten below 200 copies. You can have virologic rebound. The patient was initially suppressed, but now for some reason virus has come back. Or you can have blips, where the patient is usually undetectable, but from time to time, some small amount of virus is detectable in their plasma, and that causes a great deal of concern for the patient and confusion for the clinician. Now, this has been made a bit more complicated by having much better tests that are far more sensitive. And it's been probably a decade now since we switched to a real-time PCR for quantifying virus load, and that allowed for much better sensitivity, much less variation than the old QC PCR, and an increased dynamic range. We can now, with some assays, go from 20 copies to over 10 million copies without having to make dilutions. And there's also automated sample processing, which has increased throughput and also helped to contribute to decreased variation from test to test. And because of this greater sensitivity, the way in which the tests are reported by FDA-approved assays now are come in three different possibilities. If virus is detectable, then you'll get so many copies per milliliter. If the virus is below 20 copies, which is the cutoff for quantification, but some signal is detected, it's reported as less than 20 copies. And then if there's absolutely nothing detected at all, it's reported as not detected. And when this first came into use, it caused a lot of confusion about what is the difference between being less than 20 copies and target not detected. But clinically, these are really the same thing. So what about low-level viremia? With these very sensitive assays, many patients who were previously undetectable when the assays had a limit of detection of 50 copies or 400 copies now have some detectable virus. And so persistent low-level viremia has been defined as confirmed detectable virus loads that are under 1,000 copies. And a blip is somebody who, after virologic suppression, has a single measurement that is detectable, but then drops down to being undetectable again on the next measurement. Now, why do patients have low-level viremia? There are a number of possible explanations. For some, especially if the levels are at the higher end of what we would consider low-level viremia, this may in fact be because of persistent virus replication. The regimen is simply not potent enough to fully suppress replication, and that is a concerning issue. But there are many patients who have always the same low level of viremia, and no matter how many more drugs you add, you can't seem to eliminate that last bit of detectable virus. And there's more and more evidence that in those patients, this does not represent actual replication of virus. It's that cells are activated and are releasing virus, and enough cells are getting activated, enough virus is being released that it's measurable in the plasma. But that virus is dead-end virus. It doesn't actually infect any new cells, either because it's being inhibited and is defective with a protease inhibitor, or is blocked from entering the cell, or is blocked from undergoing reverse transcription and integration by a nucleoside analog and an integrase inhibitor. And so that would mean that would result from this episodic production of virus from latently infected cells. And then non-adherence may be a cause for episodes of low-level viremia, especially if it's only occasional non-adherence. This slide, which looked at the impact of TACMAN, switching to TACMAN assays, shows how the frequency of low-level viremia diminishes over time as the duration of treatment increases, and as the duration of being mostly undetectable increases. You can see how you start off with only 40% of people after a year being fully undetectable, and then 3/4 having no episodes of low-level viremia after 4 or more years. So we did a study to look at this, and I'll show you this in a minute, but in preparation for the study, it became clear that persistent low-level viremia can be associated with increased risks of virologic failure, immune activation, which contributes to many of the adverse consequences of HIV infection beyond immune deficiency, and may have some role in predicting mortality. And major drug resistance mutations are common in people with low-level viremia. And in one study of nearly 8,000 specimens, there was about 13% prevalence of resistance. But those were mostly from patients with extensive treatment experience, and it's less clear in the context of first-line antiretroviral therapy how common resistance might be, and that was why we chose to study it. And it's less clear what to do about low-level viremia, because the detection and management of drug resistance during persistent low-level viremia is a challenge, because most commercial genotyping laboratories only accept samples with a virus load above 1,000, because the tests are validated to 1,000 copies, even though from our own experience you can certainly detect resistance mutations if you can get a result down to 200 copies or even a little lower if you really push the assay. So together with Babafemi Taiwo from Northwestern University and Joe Iran from the University of North Carolina in Chapel Hill, we did a study to look at the evolution of drug resistance in patients with persistent low-level viremia who had been followed from initial antiretroviral therapy over the long term in the AIDS clinical trials group. We identified patients from two studies, both of which had enrolled treatment-naive patients. And we identified those who had low-level viremia as having virus loads between 50 and 1,000 copies at least twice during a 6-month period. And then we obtained their samples that had been stored in our repository and subjected them to HIV genotyping to determine the sequence for RT and protease to determine if there were drug resistance mutations present at the start and then whether mutations accumulated. So we were able to get sequence information on about 85% of the patients, and we found new resistance mutations in a little bit more than a third of them. That is, mutations that emerged during these episodes of low-level viremia. Not surprisingly, the most common mutation that we found was for 3TC or FTC resistance, and then resistance mutations for non-nucleoside reverse transcriptase inhibitors, with the 103N mutation for efavirenz being the most common. When we analyzed the incidence of mutations as a function of the level of viremia, again, not too surprisingly, those who had the highest levels of viremia were the most likely to have resistance, and this was a statistically significant trend over these categories of low-level viremia. So we found in the population overall persistent low-level viremia in about 5% of the participants who had long-term follow-up. A third of those with low-level viremia developed new drug resistance mutations while experiencing viremia, and this was most common in those with virus loads above 200. Interestingly, most of the patients resuppressed, but a confirmed virus load over 1,000 was more common in patients with resistance. That is, progressing to true virologic failure happened in 30% of those with resistance as compared to 9% who had wild-type virus. So this slide here, this cartoon is meant to try and illustrate the clinical difficulty that we face, because many patients with low-level viremia don't have virologic failure and are not at risk for failure, but represent this category of people who are producing virus that is not actually replicating. But some of them are actually on the road to virologic failure. And in this middle zone, it's clinically very challenging to distinguish one patient from another. And the only way you can really figure out which path the patient is on is to follow them over time with repeated virus load tests. And there's simply no good way to know if somebody has 60 copies or 70 copies, is that person actually about to fail, or is this because they have just persistent production of a virus? We also looked at the emergence of integrase inhibitor resistance mutations in patients with low-level viremia. And this was the work of Sébastien Gallien, who at the time was a visiting fellow in our lab from Paris, working with Constance Delogère and Jean-Michel Molina. And we looked at samples from the ANRS Easier trial. This was a study that looked at raltegravir and optimized background therapy in patients and compared it to the use of enfuvirtide, and then switched everybody over to raltegravir. This study was done at the dawn of the integrase inhibitor era. And in the main trial, they had genotyped patients who had virologic failure if their virus loads went above 1,000 copies, but not those who had lower level of virologic failure. And so we were interested in asking, well, what about those people who had low level of virologic failure? There were 49 such patients who had 94 episodes of low-level viremia with a median virus load that was really quite low, just 100 copies. And we were able to get genotypes in about 80% of the samples, which came from about 80% of the participants, and found significant integrase inhibitor resistance mutations in 3 of the 39 patients. 2 of them were N155H mutations, which are classic raltegravir mutations, and the other was a less common mutation. And I'll just show by way of illustration this one slide. Here this person was consistently undetectable and then has a virus load of just 230 or 40 copies and couldn't be genotyped by a commercial lab, but when we did the genotyping, clearly evidence of a classic raltegravir resistance mutation. So low-level viremia in patients receiving raltegravir in the Easier trial was detected in about 30% of participants during the year of follow-up, and resistance mutations emerged in just under 8% of these participants, but we couldn't identify any specific risk factors for finding resistance in low-level viremia. So the development of resistance in such patients emphasizes the importance of documenting resistance and considering a change in treatment at low-level viremia, certainly if it's confirmed above 200 copies. Then John Lee, who is now an assistant professor in my division, working with Sébastien Gallienne in samples collected by Stephen Deeks at UCSF and Hiroyu Hatano, who used to be at UCSF, looked at the prevalence and significance of drug resistance mutations among patients on treatment with persistently detectable low-level viremia. And this made use of patients from the SCOPE cohort, which is a long-term follow-up cohort of experienced patients that Steve Deeks has been following for years and years. And again, we defined low-level viremia as having a detectable viremia under 1,000 copies. Patients had to be on triple drug therapy and have an available sample. We did the usual sequencing and then analyzed those results statistically by multivariate regression. I won't take the time to go through all the details here, but we had data from samples from 47 participants, and 46% of them had new resistance mutations that emerged during these episodes of low-level viremia. In those who had 2 or more episodes of low-level viremia, 44% accumulated new mutations over an average time period of about 11 months. Having fewer fully active drugs at the previous time point before the episode of viremia and more time in the study were both significantly associated with the greater risk of resistance after controlling for the level of adherence and the level of viremia. So new drug resistance mutations are frequently detected during episodes of low-level viremia compared to historically available genotypes on these patients. Early resistance genotyping or regimen switches might prevent the accumulation of these mutations. And again, as in the other study I presented, the majority of these episodes were in fact followed by a virologic suppression. The last study I'll talk about briefly was a study done by another former trainee and colleague who's now actually at UCSF as an assistant professor, Tim Henrich. and he, together with one of our HIV fellows, looked at the database of all of our patients, both at Brigham and Women's Hospital and Massachusetts General Hospital, taking advantage of this shared electronic health record, to examine what the risk of virologic rebound was using different definitions of virologic failure. And this was prompted by the switch at our hospital from the old assays to the new assays. So now we suddenly had many more patients with low-level viremia because the assays were able to detect a much lower level of viremia. And so this was a retrospective review of nearly 800 patients. We used Cox proportionate hazard regression analysis, followed patients for about 22 months, and then used some statistical techniques to correct for or control for covariates, and I won't go into the details on this. So this is the important slide to remember here. Depending on how you defined viremia, how you defined virologic rebound, the risk of rebound for patients who had detectable viremia, that is, they were in this group that had who had between 20 and 50 copies, they had a much greater risk of having another episode that was more than 50 copies, and that was statistically significant, and also an increased risk of having more than 200 copies, but the risk for 400 and 1,000 copies was not significant. And to us, what this means is if you have these very low levels, you're going to continue bouncing around in this range between being completely undetectable and having low-level viremia. But if your virus levels are low enough, you're going to have a very low risk of actually having frank virologic failure. But if you get above 200 or 400 copies, then your risk is going to be much greater. So 7% of patients had rebound to more than 200 copies, 30% had a change in their treatment, 55% resuppressed, and of those who didn't resuppress, about 40% continued with persistent viremia, 20% still remained in this sort of middle range, and there was a third of patients who had no further data. Resistance testing was attempted by the clinician. This was all retrospective, so we didn't have samples to go back to, but the clinician made the decision to do resistance testing on 34 of these 53 patients, and they got results in 2/3 of them, in 22. 9 had drug resistance. All patients with resistance changed their regimen, and 7 of the 9 with resistance then resuppressed. So very low level viremia, that is having this 20 to 50 copies, was associated with the greatest risk of viral rebound to greater than 50 and 200 copies, but not rebound to more than 1,000 copies. Lower CD4 count and younger age were associated with the greater risk of rebound, and we've seen this in many studies, especially young age. People who are younger are less likely to be adherent to their regimens. Despite these episodes of viremia, most patients were able to resuppress. Very few of the patients actually rebounded above 1,000 copies. Fortunately, although resistance did emerge in some patients, it was rare, and lowering the virus load to define full suppression in our population would have resulted in needless switching to a second or third line regimen and increased cost. So I think this study sort of illustrates the other end of the spectrum. At the beginning, I was showing you how we have to be cautious about patients with persisting low-level viremia, but we don't want to be overly cautious, and people with very low-level viremia are probably best left alone. So to summarize and to leave you with some clinical recommendations, for low-level viremia, no changes are needed if the virus load is below 48 copies. That was the old limit for one of the assays. And there's no consensus for how to manage patients with between 50 and 200 copies, except to follow them closely. But for those who have more than 200 copies, consider them as possibly having virologic failure and attempt resistance testing if the virus loads above 500 copies, or if your lab is willing to attempt to do resistance testing on these samples. And then clearly, if there's repeated detectable viremia above 1,000 copies, in the absence of drug resistance, you can try resuming the same regimen, but you have to ask, why is this patient not taking that regimen? What is it about the regimen isn't suited to the patient, and might they be better off with a switch, even if there isn't resistance, because they need something that is either better tolerated, more convenient, or something that they prefer, and then repeat resistance testing if they fail to suppress after a change. So with that, I'll thank you very much for your attention, and I don't know if you want to take questions now, John?
Yes,
Okay,
yes.
then we'll take questions. Thanks very much.